Right now, in 2026, there are some truly incredible medical marvels happening. We're looking at the groundbreaking work coming straight out of the Department of Aesthetic and Plastic Surgery at CIHSR in Nagaland, under the expert hands of Dr. Bona Lotha and Dr. Temzula Alinger. Lives are literally being changed through complex facial reconstructive surgery. Today, we're going to unpack exactly how they're giving patients their smiles back, bridging decades of knowledge from Harvard all the way to Nagaland.
I mean, just listen to this quote from Dr. Bona Lotha. "I'm presently studying the uses of the zygomaticus major and superficial masseter for reanimation. Quite exciting." I absolutely love this because it perfectly captures the genuine passion and curiosity driving this whole global collaboration. Before we get into the heavy medical anatomy and the surgical techniques, it's just so important to recognize the profound enthusiasm these surgeons have for their craft. They aren't just performing operations, they're pioneering ways to reanimate the human face.
Okay, let's dive into this. Here is our roadmap for today. 1. The Smile Reanimation Project. 2. A lifetime Harvard mentorship. 3. Anatomy of a smile. 4. The split masseter technique. 5. The temporalis flap transfer. And 6. Restoring smiles in 2026.
1. The Smile Reanimation Project, restoring form and function.
So, to really grasp the magnitude of their work, we first need to understand the condition they're actually treating. Our focal 2026 patient is suffering from what's called lower motor neuron, or LMN, facial palsy. Essentially, this is a condition where both the upper and lower facial musculature are completely paralyzed on the exact same side, and this happens because of severe nerve damage. Patients lose the ability to close their eyes fully, their mouths droop, and worst of all, they lose that essential human ability to express emotion through a simple smile.
2. A lifetime Harvard mentorship, passing the torch. Now, the innovations happening in Nagaland today, they didn't just happen in a vacuum. This timeline charts a remarkable 18-year collaboration. It all started way back in 2008 between Dr. John B. Mulliken at Boston Children's Hospital at Harvard and Dr. Bona Lotha. Over nearly 2 whole decades, they've exchanged case studies, anatomical findings, and intricate surgical techniques. It's really this beautiful passing of the torch, compressing decades of shared medical knowledge into the incredible Smile Reanimation Project we're seeing in 2026.
And what I find so fascinating here is the human element in their emails back and forth. They aren't just discussing grand abstract theories, they're debating the everyday tools of their trade. In one exchange, Dr. Mulliken actually suggests using regular nylon sutures instead of Prolene. Why? Well, because nylon is cheaper, it's widely available, and it's just easier to cut. Prolene, on the other hand, is expensive and has this frustrating trait called suture memory because of its high stiffness. As Dr. Mulliken warns, when you tie Prolene a little tight, it actually tightens even further on its own. This kind of practical, real-world advice from Boston became foundational practice down in Nagaland.
3. Anatomy of a smile, engineering expression.
Now, what's really interesting about this slide is looking at the actual engineering of human expression. These are the mimetic muscles of the face. Unlike most muscles in your body, the ones that connect bone to move a joint, mimetic muscles have a bony origin but a soft tissue insertion. They literally insert right into the skin and overlying tissue of your face. So when they contract, they pull the skin, and that's what creates facial expressions. It's a highly delicate, interlocking web of tissue.
But among all those muscles, the absolute star of the show for reconstructive surgery is the zygomaticus major. Through extensive cadaver studies, the team noted that this muscle consistently originates from the superior margin of the temporal process on the lateral surface of the zygomatic bone, which is just your cheekbone. This specific bony attachment acts as a crucial anchor, and it's absolutely vital because it dictates the facial angle and the overall shape of the cheek. Put simply, if you want to rebuild a smile, you've got to master the zygomaticus major.
4. The split masseter technique, dynamic muscle transfer.
Okay, so the masseter is that super powerful muscle you use for chewing. In this technique, surgeons actually use a portion of the masseter to replace the paralyzed smile muscles. It's wild. Surgeons carefully vertically separate the medial third of the masseter muscle. And this requires extreme precision because they have to elevate it while completely avoiding the vital neurovascular bundle. That's the critical network supplying blood and nerve signals to the area, so you definitely don't want to hit that.
This procedure is typically done in 2 clear stages. In stage 1, an ipsilateral fascia lata graft, which is basically a thick piece of connective tissue, is placed around the mouth to provide static support. Then, 3 months later in stage 2, that separated medial third of the masseter we just talked about is brought forward and sutured directly to the graft. To make it look natural and create a proper nasolabial fold, the medial flap is de-epithelialized, meaning the top layer of skin is removed and it's buried underneath a dermal flap. The surgeons literally call this the pants under vest technique. It provides both bulk and dynamic movement whenever the patient clenches their teeth.
And this brilliantly illustrates the real-world impact of these techniques. On the left, we have a 63-year-old doctor from West Bengal. She came in with what's called a pufferfish deformity, a bulky, completely paralyzed right upper lip following a previous cancer surgery. The team performed some innovative selective denervation and flap trimming, and the result on the right is her post-operative appearance. The transformation is just striking. In fact, she was so thrilled with her restored appearance and getting back some upper lip animation that she actually declined the second-stage masseter transfer. No way, right? She was perfectly happy with just the stage 1 results.
5. The temporalis flap transfer, a 1930s technique reimagined.
Now let's look at the temporalis muscle, which sits right at your temple. This was actually first introduced for facial reanimation by Gillies way back in the 1930s. The anatomy here involves some really dense layers of fascia, fat, and muscle. The middle third of the temporalis is the longest portion, which makes it absolutely ideal for rehabilitating a paralyzed face. This specific mid-portion of the muscle has a contraction capability of roughly 1 to 1.5 centimeters, giving just the right amount of strength to mobilize the face and resist soft tissue contracture.
To make this muscle lift the mouth, the surgeons use a brilliant mechanical trick. They actually use the zygomatic arch, your cheekbone, as a mechanical fulcrum. By releasing the tendinous attachments of the temporalis muscle from the jaw and advancing them down to the corner of the mouth, the muscle essentially drapes over the cheekbone. So when the patient activates that temple muscle, it pulls against the zygomatic arch like a rope over a pulley, quite literally lifting the face into a smile. It's like a giant puzzle coming together.
6. Restoring smiles in 2026, theory becomes reality.
So the crucial point is how this all applies to the most difficult cases. In June 2026, doctors Luther and Allinger faced a really daunting challenge. A middle-aged man who had suffered from left facial paralysis for 15 years following a stroke. Think about that, 15 years without a smile. His condition perfectly matched the lower motor neuron policy we defined earlier. Because of the specific nature of his facial droop and his unique anatomy, the surgical team opted for that dynamic temporalis muscle transfer.
The surgery itself is really only half the battle. Because the temporalis is a chewing muscle, the patient doesn't naturally know how to use it to smile, right? So following the transfer, the immediate management relies heavily on post-operative mirror-guided biofeedback. The patient literally has to do mandibular smile retraining, which means looking in a mirror and practicing clenching their jaw just to train their brain to use this chewing muscle to create a dynamic, symmetrical smile. It's fascinating.
Which leaves us with this incredible thought to ponder. We've seen how practical advice on things like suture memory and deep anatomical debates between Boston and Nagaland directly translated into life-altering surgeries. If an 18-year email thread between 2 dedicated surgeons can literally rebuild a smile across the globe, how will today's shared medical knowledge shape the faces of tomorrow? The legacy passing from Dr. Mulliken to Dr. Lotha and now to patients in 2026 just proves that true medical marvels are built on collaboration. Thank you so much for joining me on this explainer, and keep your curiosity alive.